Good afternoon, everyone. My name is Adam Del Molino, and I'm the Senior Director for Virtual Care and Clinical Affairs here at the Massachusetts Health and Hospital Association. Welcome to today's webinar, MHA's Innovation Acceleration Task Force Virtual Nursing Collaborative, Virtual Nursing on the Rise, Insights from Providence Health. This is the first in a series of learning collaborative webinars that we are planning to conduct over the next year as part of our Innovation Task Force. A few logistics before we start. If you have questions during the webinar, please enter them into the chat feature as we are in listen-only mode. The questions will come directly to us, and we will do our best to address as many as we can at the end of the presentation. I also want to take a moment now to thank MHA's 2026 annual sponsors and strategic partners for their support in underwriting today's webinar, which is just one of many events we offer throughout the year to connect our members with leading experts and address timely issues like virtual nursing today. I'm now pleased to introduce our presenter from Providence Health Services. Andria Moore, Director of Clinical Operations for Providence Health Services, previously served as the Program Manager for Nursing Practice and Quality for Providence in Renton, Washington. Before that, she was a clinical quality specialist and critical care nurse at Providence, Swedish. She has a master's degree from the University of Washington, Bothell, a bachelor's in nursing science from Georgetown University, and a bachelor's degree in general science from the University of Oregon. Andria, thank you so much for joining us today for today's call. I'm now pleased to hand the webinar over to you.
Great, thank you. It's a pleasure to be with you all today. And I'm very excited to share with you our journey around virtual nursing and many of the lessons that we have learned as you consider this new innovative approach to care delivery. If you go to the next slide, I would like to start with just a little bit of background around Providence and who we are as an organization. Here are just some of our numbers from the past year. We are across 7 different states. We have 51 different hospitals, 2 schools that are a part of this, as well as we have our own health plan and 1,000 clinics. We really are a comprehensive health organization founded by the Sisters of Providence, and we are more around making sure that we are able to care for the people within the communities that we serve, advancing best practices, continuing our 165-year tradition of serving all of those that are poor and vulnerable. We are really committed to touching millions and millions of lives and really enhancing care delivery for the Western United States and beyond to transform care for the next generation. If you go to the next slide, the way in which I get the pleasure of serving is within our virtual care digital health team, which really supports our telehealth portfolio as well as our expansion into virtual nursing services. This is just some of the numbers around those patients and communities that we are able to serve through virtual care and telehealth. If you go to the next slide, we have a little bit of information around our transformation and collaboration portfolios. We have enterprise solutions, which are really around, telepsychiatry and other telehealth initiatives, but we also have different collaboration services and transformation incubation programs, which is how we started our work in virtual nursing. Our virtual care digital health team, if you look at the next slide, we really are a full shop around technology deployment, product development, project management, analytics, operations, as well as clinical workflows, and manage our accounts holistically within virtual care digital health at Providence. And that is where I currently serve and sit, and where we have developed part of this program in conjunction with our Nursing Institute. Again, if you go to the next slide, this shows you just the different telehealth programs that we do offer and have as a background. As we launched into virtual nursing, we have been doing telehealth since around 2004 with critical care at Providence, Swedish, and then expanding that into telestroke and other programs in around 2014. So we have a long background in doing this type of work and innovation. The next slide just shows you some of our quality highlights around several of the programs that are on the previous slide. We take every program very, really want to make sure that we are delivering the best and doing as much as we can for those that we serve. And then if you go to the next slide, this kind of talks about how we have done some work expanding into the home and looking at that space, as well as our hospital-based collaborations, which is where virtual nursing lives, as well as some other programs that I'll highlight just a little bit around that have grown from the innovation that is virtual nursing. And then finally, just because I think a lot of folks like to know, we utilize on the next slide just an example of the technology that we use for bidirectional audio, video, etc. And this is what we have deployed to help support our virtual nursing. So if you go to the next slide, we'll get into the meat of the conversation and what we're here to talk about today, which is our journey around virtual nursing. At Providence, when we talk about virtual nursing in the acute care space and inside of our hospitals, we refer to that program as co-caring. We really wanted to look at virtual nursing as not a standalone program, but how can we reimagine our ability to deliver care as we move forward. So co-caring is how we talk about this. It's a new model of care delivery that is a collaborative partnership between our bedside care teams and our virtual caregivers. The intent is that each of those caregivers are practicing at the top of their scope to deliver high quality care and an exceptional patient experience to those that we serve within our organization. If you go to the next slide, this kind of covers why we started to take on this work. So this program started about 4 or 5 years ago. We really were looking at what we know is going to occur and that we would probably argue is already happening, which is that we have a worldwide shortage of nurses. We know that we have an aging workforce and population. We know that there is an increased amount of burnout and turnover. And we still know that our nursing schools are unable to meet the demands of the workforce that we need in order to safely continue to deliver care to the communities that we serve. Even if we enrolled every single student and we're able to meet that need, we also know that that wouldn't fill the gap. Our CNO currently has said, and I tend to agree with him in that, like, even the argument can be made that have we ever even had enough nurses to really practice in the model that we all are currently practicing in, which is primarily a primary-based nursing model. And so we know that the nursing shortage is real. It may feel a little bit better right now, but we know what is coming, and that we are going to be facing a worldwide shortage of 13 million nurses in 2030, which is about 3.5 years from now. So we started to undertake this, if you go to the next line, and really thoughtfully looked at why do we need to reimagine how we are delivering care within Providence Health. We knew that our current strategy wasn't working. As I mentioned on the previous slide, the workforce projections were not going to support what we were going to need as an organization or as in the communities that we serve. We heard from our nurses that they were burned out, they were tired, and we also knew that because of the different communities that we support, which we do support a lot of rural health, critical access areas, that we were not going to have there's going to be a potential loss of access to care for some of these communities. And so we really need to think about how could we align our future workforce strategy and leverage technology to meet those needs of our community. And so we pulled a group together. And we really started to think about how can we do this different. And so if you look at the next slide, this kind of gives you sort of what was our ideal state of how can we think about this? How can we think about delivering care virtually? What does that experience look like for our patients? How can we start to bring more and more services virtually to our patients, and maintain our caregivers and allow them to practice in a different way? And so we started with this sort of visual and kind of thinking through all of the different ways that we might be able to deliver care differently. We thoughtfully did this, as you go to the next slide, by really looking at sort of our 4Ds to transform healthcare. We needed to deconstruct the way that we practice. And so we really, really had to, thoughtfully ask our teams, like, how can we rebuild the work that you do, but do it in a way that might, create new models of care, bring back some joy in practice, um, really talk about what are those essential components to your job and your role that you need to maintain, and what are ones that could be given to somebody else or be done differently. We thought about digitizing. So how can we use automation? How can we utilize other technology to think about delivering care? What does that look like? What are those things that we need to consider as an organization in order to help support our nurses and bedside staff and virtual staff as we move forward? How do we diversify? It's really asking that question of, is this the right work for the right person to be doing? Or should we consider moving that work to a different individual? So how can we diversify that across a team of caregivers versus maintaining a traditional, nursing model where everything is on that primary nurse? And then how can we deploy that to make sure that we're able to actually meet the needs of what we are designing? If you go to the next slide, this was not something that was done by one individual team. We really had to work across multiple stakeholders. And all of us had to continue to challenge each other, challenge our frontline staff, really, deconstruct and ask those hard questions about what is the right team to be doing this work? Do we need to continue to do this work? How can we do this work differently? And really, strategically think about, as we thought about that North Star and bringing in all those virtual caregivers, what would that look like and how would that really impact the care that we're able to deliver? If you go to the next slide, we worked very, very thoughtfully with our frontline staff. And this is a big lesson, I think, for anybody who is undertaking any model of care work or any going into the virtual nursing space, is really engaging your nursing team and your frontline nurses, and really, asking them what are the most meaningful aspects of their job, what are the things that only they can do at the bedside, what are their pain points that could potentially be taken off of their plate and be done by another nurse virtually, or is there another member of the care team that might be able to take on that scope and responsibility? Consider different technologies, really trying to strive to get them to work at the top of their license and the top of their scope, and really trying to challenge them to think about how can we redistribute the workload and work differently in this environment. And so I think engaging them very early in the process, having very, very frank conversations, look at your shared governance structures, look at those partners and really ask those questions and let them bring ideas to you. Make them a part of the process as early as you possibly can when you're thinking about virtual nursing or other care delivery solutions for your organization, as this is really important to have them be a part of sort of deconstructing their role and thinking about how they can safely deliver patient care in a different model. When we went through this exercise with our nurses, if you go to the next slide, we really came to sort of this distribution of around how we would utilize individuals in these different roles, and how we redistributed this work and thought about what could be done digitally over a virtual nursing platform, and what really did need to maintain at the bedside. And so you can see that as we went into working with our virtual nurses, we really looked at some of those things that really required a lot of sort of administrative time and really took time for the nurses to do. So around admissions, discharges, patient education, care planning. You can see that as we get into the lower part, we talk about nurse mentoring, checklists, pre-procedural, et cetera. We envision that this list will actually grow the more that we become mature in our practice around virtual nursing. This is definitely not, the most top of scope work for our nurses. We know that they're capable of doing more, but this is where we really started as an organization. For our bedside care teams, we really kept it to the physical assessments, the hands-on patient care. We have creating and documenting nursing care plans in there, but that really goes across to the virtual nurses as well. But those things that really require that hands-on patient care. And then we really looked at how can we leverage our CNAs more, ensure that they're a part of the care team and taking on some of those things that is well within their scope, but perhaps they haven't been able to get to because their patient assignments have been so large and they have been spread so thin. So what are those things that they can do? And then what are things that we could eventually, potentially train them and bring within their scope to help support the bedside care team? And we would be doing all of this by integrating in the technology into the room. So utilizing those cameras that I showed earlier and making sure that we were able to install one of those into support each bed in our acute care units. What that looked like, if you go to the next slide, for some of our teams is we redistributed the workload and we really moved from a primary nursing model, which we've kind of depicted on the left side of the screen, and moved to a team-based model. It's really hard to capture what the team can look like, but in several of our ministries where we deployed this, each nurse was working with a dedicated CNA, and they were caring for 6 patients, and they were also supported by a virtual nurse. So now every responsibility that would have been on the nurse as a primary nurse has been distributed across a care team, and we had to shift the patient assignments to help support that. I know for a lot of people, you're like, oh my gosh, this is very, very different, but this is team-based nursing. This isn't an apples to apples comparison in regards to what we were expecting our nurses to practice in what they had historically been trained and had been practicing in. This is a new model. And I think that this is a really big learning and a really important part to have conversations about, is that it is a team that is now delivering care for a patient and a patient assignment. It's not just an individual nurse who is responsible for that. Also, what is important to learn in this situation is that both of these individuals, the bedside nurse and the virtual nurse, both have their nursing licenses. They are both responsible for elements of care. And they need to be held accountable to those. And how do you build that trust between those teams? These are learnings as you think about how do you do new care models. An additional thing in this is really that RN to CNA relationship, and how do we support our bedside care teams in feeling comfortable around delegation and making assignments and holding folks accountable. These are part of the conversations that you need to have as you think about integrating new models or new individuals into your care team, or you're expecting them to work differently, because this is very, very different than how they've probably practiced for many, many years of their professional practice. And we're asking them to really think about that differently. If you go to the next slide, we are, one of the questions that we get a lot and that we have, especially practicing on the West Coast, is we do have a lot of unions and state staffing laws that we are trying to work within. It requires a lot of change management, and that's what I've kind of alluded to in regards to the need to engage your staff early and often in the conversations and really be able to speak to them about how this is different than the way that they have been trained and educated and have been practicing for years. And it's a lot to comprehend and to shift that thinking, and to say that you cannot compare those two things in the experiences. We do, really work very closely with our labor relation partners, as well as our folks who help support us with our state laws, et cetera, and really making sure that we're engaged in those processes to have conversations. With our virtual nurses at the different hospitals that they support, we hire them into the collective bargaining agreement. We really do want to have a very positive relationship with the unions that support our different facilities. And we want them to see the value that these virtual nurses are going to bring, not only to their current bargaining members, but also to the patients that we serve within those communities. And of course, through this process, we have been hit with every sort of union action and have navigated those very successfully through good open dialogue and partnership with those individuals. And so it is something to consider, but it is something that you can navigate. If you go into the next slide, we also wanted to be very thoughtful in who we brought into a virtual nursing role. And we would encourage, as you think about these individuals and how they're going to be supporting, what is it that you're looking for as you hire and onboard virtual nurses? Really making sure that they have experience in the care setting that they would be supporting. So for a majority of our initial sites, that was looking at 3 to 5 years of acute care experience. They need to be tech fluent, and this isn't necessarily something that we get trained to do in nursing school, but really making sure that you feel comfortable navigating different care, different settings, teams, whatever platform your video may be delivered through, et cetera. And making sure that they are very adaptable and very much self-motivated to really lean into this space, because it is a new practice area. It's a growing practice area. And we want our virtual nurses to feel empowered to engage with our care teams and our patients and really make sure that they are able to integrate into that team. I think the other part is, involving one strategy that has been really successful for us is, hiring somebody from whatever unit they're going to be supporting into that virtual nurse team. So it's a trusted partner and kind of helps build that collaboration and that trust between both the bedside care team and the virtual care team as we think about how we're able to support in that new environment. So it's something to consider. We do have a very specific sort of onboarding and orientation pathway that we take. We have a foundations course as well as unit specific education if they don't already support that union. And then unit, I'm sorry. And then we also make sure that we engage in precepted sessions with experienced virtual nurses. We're very lucky now that we have quite a pool of virtual nurses that were able to pair and have that precepted session versus our first virtual nurses that kind of had to train themselves as they were going through. We've seen some really great success with this program. It has not been, just this perfect, linear progression. We've had a lot of ups and downs, and we are continuing to improve. But if you go to the next slide, when we look at our outcomes from last year, and what we've been able to do with this program, and we are really excited to see it to continue to grow, is around what these virtual nurses are able to do. So they have given over 1 million minutes of care in 2025. We have improved our emergency department workflow with our first ED pilot. We see a faster discharge on our acute inpatient units. We see improvement in our top box scores with patient experience, and we see that we are continuing to improve the quality of care that we are able to provide for our patients and improve their experience through different assessments as well as quality auditing. So this was just a highlight of some of our 2025 outcomes. And if you go to the next slide, this kind of shows you part of where we are. We're in 10 different hospitals. The active implementation in units probably needs to be updated. I think I have close to 30 active implementations right now, and more units have definitely gone live in the past couple of months. We have a goal to expand this as much as possible to our emergency departments as well as our acute care units across our 7-state footprint. And we're working very closely with our operational leaders on how do we prioritize where we go next, because we do believe in this as an organization. And it is one of our main strategies to help improve the, continue to be a good partner and continue to be able to serve the communities. So if you look at the next slide, this kind of gives you a little bit of the journey of where we've been. We started out at one hospital with one unit. Now we really look at facilities and try to take up, their acute inpatient as a holistic med surge go live. So taking up multiple units at a time versus taking up a single unit. It helps with the change management as well as with the adoption of the virtual nurses. It also helps with the business case a little bit more because you're able to scale the solution more broadly. We also have looked at our ED model. We did a prototype last year and now are expanding very rapidly because of the improvement that we've seen there. We're also working on how do we optimize the workflows of our virtual nurses and how can they support other key initiatives across the organization. So looking at programs around sepsis surveillance, how can we get them set up, patients set up for appointments, things like that. Really making sure that we are trying to progress care as thoughtfully as we can, as well as making sure that we are able to impact those nurse sensitive indicators through virtually supported roles. And really also, we've started to look at different integrated workflows. How can we partner with our colleagues in pharmacy, case management, wound, et cetera, to leverage the technology to provide additional support for these patients and also allow them to gain some efficiencies by not necessarily having to go throughout the organization. And then we're also looking to explore new care areas and how can virtual nursing function within those spaces. One program that we do want to highlight because we are very excited about it is, if you go to the next slide, is what we experienced in our emergency department. As we started into the acute inpatient setting, immediately our emergency department partners were saying, hey, have you thought about bringing virtual nursing into this care area? As you can imagine, there's lots of opportunities there. One of them really is how can we help support our patients within the emergency department. We know that there's a lot of waiting. There's a lot of, shifting priorities based on the acuity of patients that are rolling in, and how can we put somebody who is just there to ensure that they're able to round on those patients, let them know what is going on, and then actually progressing them through their experience as they may be ready to discharge, or we may be reading them tests. How can we help transfer them back to skilled facilities, et cetera, while they're waiting? And we really saw exceptional results in this space based on the pilot, and really showing a demonstrated improvement in ED throughput just by adding the virtual nurse for one shift between 11 a and 11 p. If you move to the next slide, this shows where we started with workflows for those virtual nurses. So around pain reassessment, rounding, education, and then helping with throughput around admissions, borders, and discharges, and being able to help move those patients throughout the emergency department. We're getting into the area where we're going to start looking at some of these additional and proposed secondary workflows, which is very exciting as we have seen the program grow. As I mentioned earlier, we also saw we're doing some really exciting work, if you go to the next slide, around telewound. I think we all know that there are a lot of wound consultations and not as many wound nurses as we all need to help support this specialty. And so we were running a few pilots around how can we leverage different pieces of technology to provide this service to our different facilities. And it's been really, really great to see how that's grown. If you go to the next slide, it kind of breaks down how we are looking at the different roles and responsibilities, what we've identified as something that could be done virtually versus the ones that remain with the bedside care team, as well as those that can go to either one. So really using the virtual nurse for that early identification and treatment, care coordination and surveillance, and then still needing that bedside team to help do the initial wound consultation, photographs, as well as the treatment and care for the virtual nurse, or for the wound. My apologies. And then if you go to the next slide, another program that we've been working with and where we are really trying to leverage some of our virtual nurses is around sepsis identification and monitoring. We know that this is a huge important organizational priority for a lot of individuals, and how can we improve sepsis outcomes. And by utilizing virtual caregivers who can cover a broader swath of patients across multiple facilities, sometimes they are able to really reduce sepsis mortality by leveraging different sets of virtual tools to help support those evidence-based clinical workflows. If you go to the next slide, again, this is showing kind of how we are leveraging the different teams to support that and really impact outcomes for our patients, and really thinking about how do we leverage scale across multiple sites. Again, it's really thinking about how can we use our nurses differently and in different ways to help support more patients to ensure that we are able to deliver the same quality of care across the different facilities that we serve, given what we know. It's also really important as we think about our virtual nurses, and where we've been very, very intentional in our design, is that we really do want our virtual nurses to be remote and to not be in our facilities, or they need to be at an offsite, because we know that one of the things that happens very frequently is they do get pulled over if we are short staffed, and then that really leaves a gap within that space. So again, for all of these programs, we are trying to make sure that they are very much remotely located. And then just a little bit of a preview into virtual case management. Again, if you go to the next slide, really trying to leverage virtual case management in a lot of our critical access and remote locations. We have 3 ministries that are up in Kodiak, Alaska, Seward, and Valdez. And as you can imagine, those are very hard to, one, get staff into, but also then to make sure that we're able to support them. And so how can we use virtual care to support those patients and their care coordination? So going to the next slide, that just shows how we have kind of broken that up. And then finally, if you go to the next slide, another program that is around a partner of nursing is around virtual pharmacy, and how can our pharmacists go up and do those medication reconciliations, those transitions of care, consults, etc. I don't know if any of you have worked in an aging facility, but waiting for an elevator sometimes can take a very long time. And if we have that in-room technology, a pharmacist is able to beam in and speak to the patient, complete that, and really anticipate that this will lead to some really great outcomes for our patients. And so we're excited to be bringing that into this care space. So before we get into the questions, if you go to the next slide, this really is just a reminder of that there's a lot of opportunities once you bring in the technology to really leverage different members of the care team to practice virtually. So it goes beyond nursing. This really is an exercise for us to think about how can we best meet our patients' needs through hybrid virtual services, and how can we innovate in that space and think differently about the way that we've delivered care. Because we all want to make sure that we're able to continue to get our patients what they need when they need it, and make sure that they're receiving the care from the right individual in that space. And so that is part of our journey, and where we continue to look at things frequently around how we can do it differently, and have innovated in this space. And so that is our journey so far, and we're continuing to do so. And with that, I can pause, and I think I do see a question here around working within the emergency department and that model. And it's a great question. It's one that we get frequently when we start talking. So yes, the virtual nurses, what we have done is they're not in the emergency department. They're remote. As I mentioned, we really do try to keep our nurses outside of the departments and facilities that they're supporting, so that they don't get pulled into bedside care activities. But yes, we have actually started to install devices into our emergency departments and have their own dedicated fixed wall-mounted device where they're able to have that bi-directional communication. As I'm sure anybody who's walked through an ED or who's been in an ED, I recognize that there are bays and hallway beds and different treatment areas. And so we are still innovating and partnering with our sites on how best to look at that, and whether it's bringing in a cart in that space, et cetera. And so the ED is its own special area where we are still trying to thoughtfully think about how can we continue to bring the technology into that space. But for right now, what we focus on is those areas where we do have a wall space where we're able to mount a device and have the virtual nurses support that care area. And then in regards to how do they communicate back and forth, we leverage sort of secure chat or in-house, whatever your electronic record might have for nurse to nurse communication, or we also leverage Teams part of bringing on any of our sites and is that clinical integration workflow where we really get to know what are your communication pathways, how do you do this, and then how do we build those between those two care teams so that we have a way that they're able to talk to each other and support the team, as well as how do we escalate any needs at different times. So that is how that works. And it's a shift because we recognize, the putting the device in the room is just only a part of it. Yeah. Getting our teams to leverage tools that many of us are very comfortable with and to use tools that they probably have had access for a while, but maybe have pushed aside is another part of the journey in this space.
All right. Andrea, I'll be your moderator for you because I know you're answering all these questions and really appreciate you taking so much time to work with our folks. Yeah. A question comes in from Beth, and she asks, have you noticed a decrease in nurse turnover and burnout?
Yeah, so really great question. And this is one that we keep a very close eye on because we do, our intent really is to make this a good thing for our nurses. The turnover is tricky because some of our sites have had no turnover for many, many years, and then we brought it in and they still didn't have any turnover. Other sites had a lot of turnover and then we saw it decrease. So I think we are very lucky in that we've seen our turnover remain pretty consistent throughout this process at a lot of our sites, and we haven't seen it get better or worse. But we do know that our nurses really do appreciate the virtual nurses. I think one thing that always kind of comes out as we've gone on this journey and just being very transparent is they're like, we don't want the virtual nurses. This is ridiculous. We're not going to do this. Like, what are they really going to be able to do for me what you say they are? And after about 30 days, they're like, you're not taking the virtual nurses away, are you? Like, we really appreciate what they do. So the virtual nurses, I think, help our teams a lot. Where we continue to have challenges is when we shift the bedside care model and really, thinking about how can we practice there differently. And there's a lot of opportunity, I think, in that space. And we've been really thoughtful about how we approach that and what that looks like. But the virtual nurses are definitely supporting our care teams and taking some of that burden from them and helping them with those elements of care delivery.
All right. So, next question. My colleague Kim wants to know, can you talk more about the patient experience and kind of response feedback to virtual care versus bedside in-person care? And are there generational differences?
Yeah, that's a great question. And yes, I think initially when we started out around this, and this is where I would say engage your communication partners, think very thoughtfully about how you can distribute that FAQs and talking points. I think initially a lot of our patients were like, oh my gosh, what are you talking about? You're going to bring in this virtual care team. And I think a lot of that was the confusion around, is it an actual person or is it an AI person? Like, who is this individual? We also have a lot of communities that are fiercely protective of our nurses and the facilities that they go into to get care. And they're like, are you getting rid of nurses? Is it going to change anything? And I think the more that we proactively talked about, like, no, we're not eliminating nursing jobs. This is an actual care. This is an actual nurse. Like, here's their badge. Like, we hire them. They're an actual person. This isn't an AI nurse that you're talking to. A lot of that put them at ease, as well as talking about the technology and like, it's not recording you. Like, it turns away when we're not having this experience. Like, this is all your information is very, very safe and protected. I think that put a lot of folks at ease, and they just became more and more comfortable with it. And then I think we also really started to leverage those patients that had really amazing experiences with their virtual caregivers and started to share those more broadly. And that's where we really started to see the shift in momentum is around the sharing of those experiences. And the patients really started to appreciate it because the virtual nurses, they started to notice were able to come in and just kind of be with them and be uninterrupted. And when you think about your bedside care teams who have their different phones or their pagers or somebody coming to grab them, and here you have this virtual nurse who's like, hey, I just want to go over your discharge instructions with you again, or that was some really hard news. Do you want to talk about it? It really shifts how they were looking at the virtual nurses. Of course, I think with some of our older patients, it takes a little bit longer to kind of explain that, or any patients that may have um, different mental health challenges and things like that. We have to approach each patient as an individual. That doesn't mean, though, that the virtual nurse still isn't able to support that bedside care team. It may just look a little bit different. And so a lot of experiences in there, and being able to talk through them and think through them has been important for our care teams. But a lot of our patients are very, very appreciative and really like the experience of having a virtual caregiver who comes in and helps care for them.
All right, great. Next question coming in comes from Hyam, who asks, amazing, amazing work. What technology have you decided to use for this work? And have you tapped into your retired nurses? Or it seems like many of them are tired, but working from home seems appealing.
Yeah, I think that's a great question. So we currently leverage Teladoc as our vendor. But it is, a bi-directional audio video camera. And, these cameras are really incredible in what they're able to pick up. And so we have those that we are installing into each of our rooms. We have looked at this as a retention strategy, or a potential way to retain our nurses who are at different points in their career and who maybe cannot function at the bedside, fully for 12-hour shifts. There's a wealth of knowledge there, and they have a lot to offer. One of the biggest things that we have to evaluate as we hire and onboard these nurses is how are they able to interact and function with technology, because this is a huge component of functioning in the virtual world. Is are they able to do that, and are we able to help them along that way? We're not training them to be virtually savvy. We're trying to train them to use a platform and then apply their nursing skills and experiences through that. So some individuals, yes, it's great. And we are very lucky to be able to retain them and keep them within the workforce longer. And others, it is a steeper learning curve, or it is one that they just aren't interested in. We do also have a few of our locations where they offer this as sort of a hybrid role. So like they can work 2 shifts at the bedside and they can work 1 shift virtually and work remotely. And that's a huge satisfier for our nurses as well, as it just kind of makes it a little bit more, they get to experience both sides. And so they get to do some of the work that they really love, where they're able to spend a lot of time with the patients, but they still get to go in and have that interaction with their care teams and patients, which also can be very satisfying for our nurses.
Awesome. All right, next question comes in with regards, and this kind of goes back to the technology, but are there privacy concerns raised by patients or families about having a screen in the room at all times, or a camera in the room at all times?
Yeah, it does get raised, but we do talk about it on admission for all of our patients. We've built this into sort of our script for our bedside nurses as well as our virtual nurses, in a way that they introduce on admission what's going on, to answer those questions around them and let them know. The screen that is utilized for the virtual nurse to go up is just their TV. So they're used to having a TV. And when we talk about the device, the camera, it does swivel. So we're able to tell them, like, if it's turned the other way, you can know that, like, we are not in here, and we do knock and ask if we can come in, similar to how we would expect any of our nurses to enter a patient room, which is to first ask and say if it's okay for us to come in. And so that really does put people at ease. And then, telling them we're not recording this, and it's not, it's similar to FaceTiming, and that this isn't being recorded. And that usually puts most of our patients at ease. I think the other thing that we have learned through this experience is that for a while, we kind of made it seem like it was a choice that this virtual nurse would be participating in your care. And people would be like, well, I don't want a virtual nurse. And I'd be like, oh, well, okay, that doesn't really help. But we've been very thoughtful about how we introduce virtual nursing. This is a member of our care team. This is employee. This is somebody who's going to be helping you, similar to like a pharmacist or a case manager. Like, it's not like you get an option to sort of opt out of having this person participate in your care experience within our facility, because they are going to ensure that we are able to deliver top quality, safe care to you. So that is how we've kind of thought it. And we see those trickle off more and more, especially as the program has been within different areas for a while.
And that includes microphones too, right? Like, people have the microphones are turned off and the camera's all turned off when they're gone.
Yeah.
Okay. Next question says, would using the unit nurses so that one day of their assignment is virtual nursing from home, is that a pleaser? Is that something that the nurses really like and adopt?
It depends. It really does depend on the nurse and the location. There are some nurses who are like, I don't want to do that. And there are others who might find it to be a satisfier. I think the other component of that, though, that we have to take into consideration is that there is an expense of setting up a virtual nurse, and that they do need to have, a space where they can work remotely, typically within their home, which then requires us to provide them with, their desktop, multiple monitors, and things like that. And so I do think that if you're considering a virtual nursing program and you want them to maintain that, you're going to have a smaller pool. It's not something that you're going to offer to everybody, but there may be some nurses where that very much is a job satisfier, and you would want to be able to consider that type of option. But it may increase staff versus having a set of core virtual nurses who are just fully practicing remotely. We do also occasionally set up, a hub or a desktop at many of our facilities so that in case for some reason our virtual nurse, something happens at their home, they cannot, log in, that they are able to go in. However, we do have part of why we're looking at this is how do we leverage workforces differently, is that we do have nurses who do not live within, what would be an acceptable travel distance to get to one of our facilities. And so there's a variety of different ways that you can design it and need to think through it as you build up your program.
I like that thinking about redundancy too, because if your services aren't always working and if there's a power outage or something else and you don't have access to broadband anymore, that you can't really kind of provide that care. So you have that redundancy to come into the facility. That's huge.
Yeah, it's we live in fire country, and we have a lot of our sites that run that risk sometimes. So
we're in a place right now where we're getting 10 inches of rain in some parts of our state over the next 2 days. So it's going to be really interesting to see what happens with flooding,
yeah.
which I know you guys have that experience out there too sometimes. Um, so quick question. I know you mentioned previously you were talking about case management and discharge. And I know that in Alaska and in Washington State, two of the areas where you've kind of implemented these programs, throughput and discharges have been a little bit of a challenge, especially during the pandemic. And I know they've done some research and collected some data, particularly in Alaska, about throughput. What have you seen in terms of how the virtual nursing has assisted those hospitals in terms of discharges and moving people to the most appropriate post-acute care levels?
Yeah, we've seen a lot of really. We have several facilities that have done very thoughtful projects around how can they improve this, and what they've been able to demonstrate in partnership with on-site case management has been really, really significant, and seeing some, initial results around, readmissions or getting them to the right space. It hasn't been statistically significant, so it's not something that we, publish, but anecdotally, we do see that we're able to get our patients better set up when they go home, knowing that they have, we have all their prescriptions set up. We know that they have their appointments. We've coordinated with them in a different way than typically, and also getting those low risk sort of patients that may not qualify for a case management, having a virtual nurse kind of take on those things and making sure that they are really getting that complete discharge experience has really led to improved outcomes in that space. And with our case management, especially with our rural hospitals, it's just good to get them the support so that we can actually do the things that are, considered sort of the what you would consider sort of a minimum expectation, just because they don't have the same level of coverage as many of our big ones. So how can we get those resources to the sites to make sure that we're able to do what we know is best for the patients, and not necessarily even have to optimize workflows or think about how we do it differently, but how can we get those resources to more patients in the locations where they are? And that's part of what is great about what we're really approaching as building our virtual highway, so that our caregivers can travel along a virtual highway versus having to physically go to these locations and be able to intervene with these patients, but they are able to really just virtually meet the patient where they are when they're in one of our facilities and get them the things that they need. And so that is our goal behind it. And we do anticipate that we'll really see some more profound outcomes once we're able to scale this more as a solution.
It's fantastic. Knowing that those distances are so big, that's a huge deal, especially like way up in Alaska, but even Washington State, it's a lot bigger than Massachusetts, and the distances are so much farther than you can even imagine. And there's so many more rural facilities than there are here.
Yeah. So we're excited to see where it goes. And we're lucky that we have some partners who are willing to take it on with us and kind of be our test cases. And we really look forward to learning from them and then thinking about how we can apply that.
Awesome. So I think there's a couple more questions, and if folks do have any questions, please feel free to enter them into the chat right now. Um, Next question coming in says, would using the unit nurses so that one day of their assignment is virtual nursing? Oh, that we already asked that one. Okay. That was the question we just asked. Sorry about that.
That's
I don't have any other more questions in the queue right now. Um, just if you were starting up and starting out with
yeah.
a virtual nursing program, what would you what would you recommend to a hospital or a health system that's considering entering into virtual nursing? And what would be the three things that they should really focus on as they're trying to lift up and scale a program?
Okay. So the three things. One, I would say engage your nursing staff from the very beginning. Uh, Pull them into halls, talk about, um, ask them the question about if we could do things differently, how would you do it? What does that look like? And I would say you put the one caveat around it that adding more bedside staff is not, that's the only thing that's sort of like off the table. Because you really want to get them engaged in the thought exercise around how can we practice differently and give them the why. I think that's really, really important for every single team to do with their nurses so that they are an active part of the solutioning and part of they'll tell you what workflows they need you to tackle to help them buy in and find value in the program. I would say the other part is engaging your finance leaders as soon as possible to build your business case and making sure that it ties to things where they're going to be able to be your biggest champions around the program. Is you really need them to buy into what you're trying to do and really getting that support. So I think engaging your frontline staff as soon as possible, making sure you have a good finance partner. And then I would just say be ready for change management and have a change management strategy in place or a really thoughtful approach to it because this is a lot of change. We're really shifting in how we are asking nurses to practice. And we are shifting how their day-to-day goes. And that is a big ask. And so you need to be very thoughtful in that approach and really make sure that yourself and your leaders are ready to do that because it requires sort of that you got to go with them on the journey and help them through the change because it's really, really hard. Once you get there and they start to see it, then I think it does get a little bit easier and they're starting to see more and more value and more people are like, come to me, I want to take this on. But I think that those are the biggest lessons learned and where you just need to be very thoughtful in your approach in order to be successful.
Two questions came in just as we've been sitting here talking, so I'll give it up. And Michelle says, "Hi, and thank you for this information. For public health nurses and innovative practices that include community-based prevention, harm reduction, and care coordination slash accessibility that might include higher risks and trauma-informed care, do you have thoughts around risks and liability in the government spaces or maybe policy spaces?"
In the policy, yeah, I think there is. I think we have. This is, telehealth and virtual care delivery. I think we'll continue to see shifts in how that policy gets shaped. But I think that is one where we just need to be engaged in it, and we have very thoughtful leadership who are really, leaning in and what does that look like. I think that's also part of when we look at a workflow. Or if we look at going into a space, we do a very thoughtful discernment as an organization, and we have a lot of partners who look at the risk and the liability around that, and how do we build those contingency plans? How do we approach that thoughtfully? But also, how do we not get in our own way of thinking about how can we innovate it? And just because they say that we can't do it, is that what is the rationale behind it? Like, and do we need to think about approaching it from a different lens. This is part of one of our challenges as we think about scalable solutions and how do you support across state lines? How do you hire a nurse in one state? Like these are all questions that you kind of have to tackle as you go into it, but it can be done. And I think we need to make sure that we have our proponents and our advocates to continue to engage in that advocacy space to make sure that we don't create a whole bunch of restrictions and then can't really leverage the technology to deliver care in a thoughtful, safe way to meet the needs of our patients, because we are going to have an influx of patients that need a lot of things from a lot of health professionals, and we are not going to have enough health professionals who are going to be able to do that in a physical space like a hospital. So
As the questioner put it in the chat, well said, well put. Thank you. And Sandy asked a question as well. Did this program change your on-unit staffing model? And I think you said yes. So go ahead and feel free to just reiterate it again.
Yeah, I would say on some of our units, we have shifted the on-unit staffing model. We have worked because when we initially started, it wasn't just bringing in a virtual nurse. We were also shifting how did we deliver care at the bedside and leverage CNAs and nurses in a team-based approach differently. So how do we apply all of those things together? And so that is how we approached it. In the emergency department, we did not shift how the bedside model was shifted. We brought in just the virtual nurse to provide care over a set schedule. And then as we've continued to iterate, we really work with the care teams to understand what are their needs on that unit. Like, do they have high volume days where they have a bunch of admissions and discharges? And that's where we really need to bring somebody in. And what are the different things? Or do you have a lot of folks that need to be mobilized? And so should we think about bringing in a mobility aid versus additional CNAs? So the intent is to really understand what's going on at your units and how can you then leverage and pull different things and think about it differently. And that's why we say engage your staff to understand what their pain points are, so that when you come in and you say, okay, we need you to think about practicing differently and your assignment and how we deliver care is going to look different, they see that you've addressed those things and they've been part of the solution. In some of our states, we probably are not able to adjust things as much as we want to. We practice in California. They have very, very specific staffing laws that we are operating within. And part of that has been how can we leverage our LVNs more and bring those into our acute care spaces, and some lessons learned in that space. And so on one of our units, the model has changed and we've brought more LVNs in. So it's a mixed bag of models and how we approach this, but the true intent is how do we thoughtfully look at different models of care, and that may change what that looks like from a staffing perspective as well. Oh, you're on mute, Adam.
I apologize. I think we are coming up on time. So I just want to take this opportunity to really thank you for taking the time out of your busy day, at the start of your busy day, to join us here today and talk a little bit about virtual nursing and your model and how it's worked out for your system. We really, truly appreciate it. I think many of our hospitals are just starting the journey here in Massachusetts. But having your perspective and your expertise and your passion for nursing, it really comes through in the presentation. And we really just want to say thank you so much for taking this opportunity to join us today. Really quickly, I want to also promote a couple of upcoming events here for MHA. Our 2026 Annual Women Leaders Healthcare Conference is on December 3rd at the Westin Seaport, Boston. That is a meeting that sells out annually, so we encourage everyone to use the QR code here to join us and register for that event. And also coming up in 2027 is our annual meeting on January 14th, 2027 at the Westin Copley Place in Boston. Please consider registering for that event, as well as also an event that typically sells out. So thank you so much for joining us today for this virtual webinar with regards to virtual care and virtual nursing. We will have additional webinars in this series focusing on our Innovation Acceleration Task Force and learning collaboratives that we'll be putting together in the coming weeks and months. So thank you so much for joining us today, and we'll hope to hear from you all soon. Have a great afternoon.